Hello. Today we are going to discuss on the topic from section 1, distribution of drugs. Under this the topic is tissue permeability of drug. Myself Prashant Nayak, assistant professor, Department of Pharmaceutics, NGSM Institute of Pharmaceutical Sciences. So what are the learning objectives? First we learn about drug distribution, steps in drug distribution, factors affecting distribution of drugs, tissue permeability of drugs, organ size and perfusion rate, which comes under factors affecting distribution of drugs. What is distribution of drug? Distribution is defined as reversible transfer of drug between one compartment to another. Since the process is carried out by the circulation of blood, one of the components is always the blood or plasma and the other recipient extravascular fluid and other body tissues. Distribution is a passive process for which the driving force is concentration gradient between the blood and extravascular tissues. What are the steps in distribution of drugs? Distribution of drugs present in systemic circulation to extravascular tissue involves the following steps. Permeability of the or unbound drug present in the blood throughout the capillary wall occurs rapidly, and entry into the intestinal fluid, extracellular fluid, ECF. Second point is permeability or permeation of drug present in the extracellular fluid, extracellular unit through the member of cells and into the intracellular fluid. This step is rate limiting and depends on two major factors: rate of perfusion to the extravascular tissue and membrane permeability of drug. As you can see in the picture which is taken from the reference 1 and 2, the drug which comes, protein is bounded to the drug. After that the free drug is released near to the cells, near to the capillary walls where the blood comes, and then it is taken into the extracellular fluid. From there the drug perfuses inside or goes inside the cell membrane to the intracellular fluid, and tissue protein bound drug takes place. So this is exactly the process on which drug distribution takes place. Now what are the factors affecting distribution of drug? Distribution of drug is not uniform throughout the body because different tissue receives the drug from plasma at different rates and to different extent. Differences in drug distribution among tissue essentially arise as a result of a number of factors. The factors are tissue permeability of drugs. Under this we have physicochemical properties of drug like molecular size, pKa, oil and water coefficient, partition coefficient, physiological barriers of drug diffusion, and organ tissue size and perfusion rate. Binding of drug to the tissue components takes place, binding of drug to the blood components, binding of drugs to extravascular tissue proteins, and then we have a miscellaneous factors which is related to age, pregnancy, obesity, diet, disease state, drug interaction. Now let us see the first one, tissue permeability of drugs. Several factors listed above. The two major rate determining step or rate limiting step in distribution of drug is tissue permeation and blood perfusion. If the blood flow to the entire body, tissue very rapid and uniform, differences in the degree of distribution between the tissue will be indicative of difference in the tissue permeability of drug, and the process will be tissue permeation rate limited. Tissue permeability of a drug depends upon the physicochemical factor of the drug as well as physiological barriers that restrict the diffusion of the drug into tissues. What is physicochemical properties of drug? Important physicochemical properties of drug that influence its distribution are molecular size, degree of ionization, partition coefficient, stereochemical nature of the drug. The molecular weight less than 500 to 600 Dalton easily crosses the capillary membrane to diffuse into the extracellular intestinal fluid. Degree of ionization is an important determination in its tissue permeability. pH of the blood and extracellular fluid plays a vital role in the ionization and diffusion of drug into cell. Most drugs either weak acids or weak bases, and the degree of ionization at plasma or ECF pH depends on their pKa values. Now let us see in figure 2 permeation of unionized ionized drugs across the capillary and the cell taken from reference 1 and 2. Unionized drug crosses the capillary wall, goes to the extracellular fluid and directly crosses the cell membrane and goes to the intracellular fluid. Whereas unionized drug, large Ka and low water oil and water coefficient passes through the capillary wall but cannot pass through the cell membrane. So this is how permeation is rate limiting step for ionized and unionized drugs. Unionized drugs it passes easily, unionized drugs it cannot pass the cell membrane. Now what are the physiological barriers of drugs? A membrane with special structure features can be permeability restriction to distribution of drug to some tissues. Some important simple and specialized physiological barriers are simple capillary barrier, simple cell membrane barrier, blood-brain barrier, blood CSF barrier, blood placenta barrier and blood testis barrier. Organ size, tissue and organ or tissue size and perfusion rate. Distribution will be perfusion rate limited when drug is highly lipophilic. Membrane across which the drug is supposed to diffuse is highly permeable, such as those of the capillaries and muscles. Whereas only highly lipophilic drugs such as thiopentol can cross the most effective selective barrier like blood-brain barrier. High permeability capillary wall permits the passage of almost all drugs except those bound to the plasma protein. In both cases, the rate limiting step is rate of blood flow or perfusion to the tissues. Greater the blood flow, faster its distribution. Perfusion rate is defined as the volume of blood that flows per unit time per unit volume of the tissue. It is expressed in ml per minute per ml of the tissue. Now let us see this. From this diagram you can see, from this table you can see, which is taken from the reference 1 and 2, highly perfused organ like lungs, kidneys, in which we have percentage of blood volume is 0.7, blood flow is 500 ml per minute, percentage of carbohydrate output is 100 and perfusion rate is maximum 10.2. We can see moderately perfused organ like muscles, which is 42%, 100% in case of blood flow, 1000 ml per ml, and 20 of the cardiac output and 0.034. These are all the things. Poorly perfused organs, which is having the fats, bones, which is having 10, 200, and so on. So poorly perfused, they are fats and bone, in which we can see how much is the blood flow. In fat example is 200, 4 is the percentage cardiac output. Perfusion rate is 0.001. If K T by B is the tissue plus body blood partition coefficient of drug, first order distribution rate is constant is K is given in the equation K equal to KT equals to perfusion rate divided by KT by B. Now tissue distribution half-life is given by equation. Distribution half-life is nothing but 0.693 by K by 0.639 by K1. It can be written as 0.693 K T by B divided by perfusion rate. The extent to which the drug is distributed in a particular tissue or organ depend on the size of the tissue, that is tissue volume, and tissue blood partition coefficient of the drug. Now binding of drug to the tissue component. A drug in the body can bind to several components such as plasma protein, blood cells, hemoglobin, that is blood components, and extravascular proteins and other tissue. Miscellaneous factors affecting drug distribution. First one is age. Differences in distribution pattern of a drug in different age groups are mainly due to differences in total body water is much greater in infants. Fat content is also higher in infants than elder. Skeletal muscle are less in infant and in elderly. Organ composition, the blood-brain barrier is poorly developed in infants and myelin content is low and cerebral blood flow is high. Hence, greater penetration of drug in the brain. Plasma protein content, low albumin content in both infants and elderly. Pregnancy. During pregnancy, the growth of uterus, placenta and fetus increases the volume available for distribution of drug. The fetus represent a separate component in which the drug can be distributed. The plasma and the ECF volume, extracellular fluid, also increases, but there is a fall in albumin content. Now let us see about obesity. Obese person, high adipose tissue content can take up a large fraction of lipophilic drug despite the fact that perfusion through it is low. High fatty acid levels in obese patient alters the binding characteristic of acidic drugs. Diet. A diet high in fats will increase the free fatty acid level in circulation, thereby affecting the binding of acidic drugs such as NSAIDs to albumin. Disease state. A number of mechanisms will be involved in the alteration of the drug characteristics. Distribution character disease state. Altered albumin and other binding protein concentration. Altered or reduced perfusion to organs or tissues. Altered tissue pH. Drug interaction that affect distributions are mainly due to difference in plasma protein or tissue binding of drugs. So that's all for now. Today what we have learnt is what exactly is drug distribution, how the drug distribution takes place, tissue distribution of drug, perfusion rate limited, all these things we have discussed. Blood brain barrier, blood placenta barrier we have discussed, how the drug can pass through them. Reference is taken from Shagil textbook, Applied Biopharmaceutics, and Brahmankar and Jaiswal, Biopharmaceutics and Pharmacokinetics. That's all for now. Have a nice day. Bye.